Linda Bird is our Director of Programs and Services. Take it away, Linda.
Thank you, Marco. Welcome everyone to today's presentation, Frailty, Vaccines, and Vaccine Preventable Illnesses. As we begin, I'd like to acknowledge that we are gathered today on sacred land that has been the site of human activity since time immemorial. We are in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people, and we acknowledge them as the past, present, and future caretakers of this land. We are all treaty people. Our audience today includes people living with dementia, people caring for someone with dementia, and people who just want to learn more. We'll have a 30 to 40-minute presentation, followed by 10 to 15 minutes to address your questions. During the presentation, if you do have a question, please type it in using the private confidential chat box at the bottom of your screen. If you don't see it, use your mouse to hover near the bottom, and there should be a chat in the middle. After you've typed your question, remember to press enter to send your messages to us. Your questions will only be seen by ASNS staff, and we'll get to those at the end of Dr. Andrews' presentation. So to begin today, I'd like to present Dr. Melissa Andrew. Dr. Andrew is Professor of Geriatric Medicine at Dalhousie University. She is an associate member of the Canadian Centre for Vaccinology and co-principal investigator of the Canadian Immunization Research Network Series Outcome Surveillance Network. Here she studies how frailty impacts influenza and COVID-19 vaccine effectiveness and clinical outcomes, especially in older people. She has worked on including frailty in vaccine clinical trials, and she serves on the scientific and executive committee of the Global Influenza Hospital Surveillance Network. Welcome, Dr. Andrew.
Thanks so much, Linda. And thanks for the opportunity to speak with you today about this issue around vaccines and why they're important for our populations, especially older people. I'll start with my usual disclosure. So this is where, when one is presenting a talk, we talk about, like potential for conflict of interest and that sort of perception. So I have been funded by various organizations, including some vaccine companies, but also including the Public Health Agency and the Canadian Institutes of Health Research and Canadian Frailty Network, to do these research studies that I'll be talking about today. And I'm also a member of NACI, which is the National Advisory Committee on Immunization, the one that you hear about on the news these days. And I don't speak on behalf of NACI, but I speak on behalf of my own experience and research. So I wanted to tell you about 3 key points today, and we'll try to weave these through the next half hour or so, and then hopefully they'll resonate with you. So the first one is to talk about how when people get older, and especially when people have frailty, which we'll talk about what that means, there are changes in the immune system, which can impair the function of the immune system when it comes to protecting from infections, but also when it comes to responding to vaccines. So that means that vaccines may work differently in older people compared to younger people, and we need to understand that. The second point is that these infections that can be prevented by vaccines are really very important in terms of causing bad things to happen in terms of people's health and their health outcomes. And that impact is not even just in the 2 weeks of having an influenza or COVID illness. This can be a long-term impact, and we'll try to unpack that a bit later on. The third point is really a practical one. So we know that these infections can contribute to people getting worse in terms of their health and their frailty and their dementia. So it's important to do what we can to avoid that, and we'll talk about some practical strategies. So people often wonder why we're connecting these ideas of frailty with vaccines and infections. And it's actually fairly new to be combining these disciplines, but I think it's leading to some really important observations. So first of all, we want to make this connection between frailty, immune system function and infections, and dementia. Of course, for today's audience, we're focusing on brain health as well. And so there's really quite a lot of evidence that connects frailty with dementia, meaning that if somebody is frail, and we'll see what that means, but it really has to do with being vulnerable to bad health outcomes, having a lot of medical conditions and functional dependence. That's what frailty means. So people who are frail tend to have higher risk of dementia symptoms, and being frail can make the changes in the brain that come with dementia more prominent in terms of their symptoms and the degree of impairment that they may have. So I've colored that arrow quite dark color because we know that that is quite a strong relationship. Now, we also know that infections and the immune system have an important relationship with frailty, but we're still working on understanding how exactly that works. And it may, in fact, be some of these immune changes and previous history of infection that cause people to become more frail. So there's an important relationship there. We also are beginning to understand how there can be some immune system implications in dementia pathology and what's going on in brains when people have dementia and memory problems. And that is really just being understood now. So there's a lot yet to be understood, but there's certainly some evidence of relationship there. Now, importantly, one of the ways that that relationship happens is through what we call delirium. So delirium is when somebody who's got an infection or another medical condition gets acute confusion or worse than their usual baseline because of that new problem like a pneumonia or an influenza or COVID. And we know, in fact, that delirium is a common way that some of these infections present when somebody's older and frail and has dementia. But we also understand that delirium is an important driver of getting worse in terms of dementia and even a risk factor for developing it down the road. So some of this relationship between the immune function and infections and dementia will happen with delirium. And then, of course, we also know there's an important relationship between being frail and having a higher risk of delirium. So really, we can see that this is all tied together in quite complex ways. So just to get back to what frailty means, it might be a concept that's familiar to many of you. What we mean there is this state of being vulnerable to poor outcomes when it comes to health. And it's also about the ability to resist or respond to a stressor event. So here we have this on the y-axis here. This is like up high is people who are less frail. That also means they're more independent in their activities of daily life. And if they're functioning at quite a high level, they may be able to tolerate an illness like an infection, an influenza, or COVID fairly well. They'll have a period of being worse than their usual level of function during that illness, but then they'll be able to recover fairly rapidly to get back to or approximately back to their previous level of functioning. However, people who are frail are really teetering on that edge of being dependent and not being able to manage on their own in the community. And those people are extra vulnerable to having that same illness, like an influenza or a COVID or a urinary infection, cause a much bigger decline in their abilities and their health status. And then they may take a long time to recover and they may not get all the way back to where they were before. So that's really what we mean by frailty. These are the people who are vulnerable to that sort of thing happening. There are different ways of measuring frailty, and these have been used in some of the research that I'll talk to you about shortly, but one of them is a very physical definition. So this would say that if you have 3 of those things that are listed, so if somebody has weakness, weight loss, and they walk slowly, then they would be considered frail. And it's really very narrowly defined, though. So it's not a definition that we tend to use as much in these studies that I'll tell you about shortly, but I think that many of you will appreciate that frailty and this vulnerability is much more than just these physical things. So when we think about broader definitions of frailty, this is a commonly used one that was developed right here in Nova Scotia by Ken Rockwood, who many of you would have perhaps heard of, and colleagues, and we've been working on research about it since over many years. And this is a scale where everybody would fit on this scale, from the very fit people who are able to, go out and do running and play tennis and whatnot, to people who are quite dependent in their basic activities of daily living and would be severely frail. So this is a way of categorizing people along this sort of spectrum from being very fit to very frail. So we use that in some of our studies that I'll tell you about. And another one that we use that's a really interesting way to give a very graded measurement of frailty is to understand frailty as the accumulation of health problems like medical conditions, functional problems, eyesight and hearing difficulties, having falls, all of these things kind of put together. So it's really a much more inclusive measurement of frailty. And what we do is we add them all up and make an index. And that allows us to have a very fine gradient from people who are not frail at all the way to the most frail people. And this is one that we have used in some of these studies too. So the first point is that the immune system changes with age, and that affects the response to vaccines and infections. Okay, so let's get into this one. So just as a small primer on the immune system from me, a non-immunologist, is that sometimes we think of the immune system as really just being about antibodies. We hear about antibodies and they're very important, of course, but that's only part of the immune system. When people are born, in fact, before they have a chance to develop these antibodies and have exposure to infections and other agents, we rely on this part of the immune system called the innate immune system that really has a lot of different components. Some cells that are just like non-specific gobbler uppers of the invading viruses, for example. Also like inflammation that happens with various different chemicals that are released from cells to try to just bring help to the scene of an infection and be able to deal with it. So that's the innate immune system that doesn't have antibodies involved. The memory part is called the adaptive immune system. And then this has specific immune cells that then generate antibodies and responses to something you've seen before. So this is the part of the immune system that is mostly targeted with vaccines because you try to develop those immune responses that will be able to respond next time if the actual infection comes along. So when it comes to older people and the immune system, we know a few things. I mean, one is that there's this very important balance between inflammation, like those innate immune system bits that I was talking to you about before, and anti-inflammation to keep it in good balance. Because if you have too much inflammation, then you get things like lupus or rheumatoid arthritis or these conditions where people actually suffer from having too much inflammation. But then also if you don't have enough, then you have immunosuppressed people who are not able to respond in these important ways. So one of the things that we see with the aging immune system, it's not that it's necessarily always weaker. In fact, sometimes there's this thing called inflammaging, which is where there's a lot of extra inflammation that's happening, bubbling below the surface, and is not usually noticeable until you run into some issue with a health challenge, and it impairs the responses. But it's as if you're trying to drive a car and you have your foot on the gas pedal and the brake at the same time. So you don't have a smooth ride. You have this sort of jerky, uncontrolled, and not very regulated response. And that's the problem that we tend to see as people get older, and particularly we think when they're frail. And the word that is used for this change in immune function as people age is called immunosenescence, which just means sort of fatiguing of the immune system with age. But it's not about necessarily being just weaker. It's about this dysregulation or not being coordinated. And so there is this controversy about how do we measure immune function in response to vaccines or infections. And one thing that we now know, and from these studies that I've listed here, among others, is that just measuring antibody levels doesn't really capture the full story of the immune response. And so it's quite limiting to only look at antibodies. We need to look at the function of the whole system in relation to frailty and aging. So that has implications for how we do our studies, but also how we design vaccines that are going to be helpful to older people. Because of these changes in the immune system, it's been noticed that the effectiveness of some vaccines is not as good in older people. And so there are various ways to overcome that challenge, and it has to do with the design of the vaccines and also how we implement them in the population. So one of the ways that can help overcome these challenges with the immune system in aging is to have a higher dose of the antigen, which is the thing in the vaccine that the immune system is responding to. So that is one example of that is there's a flu vaccine that's a higher dose one. Another way to best stimulate the immune response is by adding an adjuvant, which is a chemical agent that causes like inflammation right at the site of having the vaccine. And that has been used in various vaccines, including there's a flu vaccine that's adjuvanted. The H1N1 vaccine at the time of the last pandemic was one of those. There's also an adjuvant in the shingles vaccine, for example, and that can help boost responses. There are newer ways of generating the antigens using different methods that are recombinant, which just means like the way that the little building blocks are put together. So that can sometimes help stimulate responses better. And we can also think about giving extra doses or booster doses. So these are all different ways that vaccines have been tailored for older people. And certainly we're still in the process of doing that to make these better. So when we talk about how well vaccines work, we talk about this thing called VE. And you might see that in some of the news stories, like the VE of, like the whatever COVID vaccine was 95%. And the one trick is that they don't always mean the same thing. So one is vaccine efficacy and the other one is effectiveness. So it may seem like the same word, but there's a subtle difference. So when they talk about efficacy of how well a vaccine works, that's based in a randomized trial. So a very defined setting of people enrolled in a clinical trial. They had to meet certain criteria to be in the trial in the first place. And they were like healthy volunteers usually. The other one is vaccine effectiveness, which is how well it works in the real world. So that tends to be quite important for us to understand for our frail and older populations and people with dementia who are often not able to participate in clinical trials. So some of the results and things that I'll be telling you about are from this serious outcomes surveillance network that we've been running across Canada since the last pandemic, so for over 10 years. And we've been studying influenza and how well the vaccines work to protect against hospitalization over the last decade. And now we're looking at COVID-19 as well. So just a few important things to highlight from that. One is that we know that older people are more vulnerable to being admitted to the hospital with influenza and having bad things happen. So here, for example, in people over 75, the death rate with influenza in a hospitalized person is about 14%, which is quite high, compared to 4% for a younger adult, which is still higher than we wish it was. Interestingly, though, and it's to some degree a good thing, vaccination rates have historically tended to be higher for older people against influenza. So that's good. We want that to be high, but we want it to be higher for everybody, in fact. And it's actually quite shockingly low among the younger adults, even those who are sick enough, who then become sick enough with the flu to get admitted to hospital. So we wish we would have been able to prevent some of those hospitalizations. Now, interestingly, when we look at it by frailty, according to how frail they are on that clinical frailty scale that I showed you, we see that older people do tend to have higher uptake of flu vaccine, but it's even higher among the people who are frail. And so that means for the astute people among you who are thinking here, that if you're more likely to get the vaccine and you're more likely to die and end up in the hospital, then if you don't take into account the frailty or the reason you got more vaccine, we'll not have a good estimate of how protective that vaccine is, because the vaccine has to work extra hard to protect the frailest, most vulnerable people. When we do these studies, and really any study of vaccine effectiveness, what we do is compare the vaccination rate in people who have the illness. This is people who are admitted to hospital with influenza, and these are people who look like they might have had the flu, but they tested negative. And we look to see how many people were vaccinated in each group. And so then we're able to figure out the effectiveness of the vaccine in preventing them from being admitted. Now, here's a few things that we've learned over the years from this research study. So one of them is that the flu vaccine prevents about half of hospitalization. So it's a 50% effective in reducing hospitalization, which isn't perfect, but it's pretty good when you consider the alternative. Interestingly, when you look at vaccine effectiveness, you have to think about what it's preventing. So usually vaccine effectiveness is a bit lower when it comes to preventing milder illness, but is higher when it comes to preventing the severe illness and death. And that's what we see with influenza too. So say for older people, it might have been 40% effective in preventing the hospitalization. However, it's more effective in preventing the ICU stay and even more effective in preventing the death. And we see that with COVID vaccines as well. So that's an important thing. It may not prevent all the infections, but it does best at preventing the severe outcomes. And we really need to understand the profiles of age and frailty when we're looking in these studies. Otherwise, we would tend to underestimate how effective these vaccines are. Here's where we're going to switch gears a little bit to another study that was looking at shingles vaccine, and this was a randomized trial. So one of these giant trials, almost 30,000 people randomized to vaccine or no vaccine. And when I read these studies a few years ago, I was thinking, wouldn't it be interesting if we could understand whether there were frail participants in that study, and also whether the vaccine worked as well for frail people as for less frail people. And they hadn't looked at that when they first did the study, but we were able to work with the data from the study to generate a frailty measure based on a frailty index that I'll show you in a second, and then see how effective or efficacious it was at preventing shingles, and also look at the immune responses and the safety and side effects. So we developed a frailty index based on the medical history and the quality of life kind of functioning questions that they were already collecting in the study anyway. And then we were able to divide the participants up into their different frailty groups. This is really the first time this kind of approach has been done in a study like this. So it's really quite innovative. So we were interested to see that there were some frail people in the study. And that's actually unusual because a lot of research studies, because of the very defined list of inclusion criteria that people have to meet, they have to be like otherwise healthy, and then they can't have this or that problem. And so they really end up excluding all the frail people. But here in this study, we did have some frail people and a lot of sort of very mildly frail people as well. And of course, that increased with age. So of the people over 80, almost a quarter of them were frail. So it was very reassuring that the efficacy of that shingles vaccine was over 90%, even for the frail people. And that was what I was at first was worried about, like making sure that what we see as a good response to the vaccine actually applies to the people who need it most. So that was nice to see. So we concluded from this study that it was quite possible to do this sort of investigation to generate a frailty index in that type of study, and that the vaccine efficacy and responses from the immune point of view were quite high. I'm going to have to take you on a small journey to get my plug because my battery has gone low. So I'm going to turn my video off and keep talking. The second point is that infections are drivers of complications and poor outcomes. And the impact of that is not just in the short term, it's actually a long-term impact. So we know about the burden of COVID, of course, that we've had millions of cases of COVID in Canada. We've had over 126,000 hospitalizations, and sadly, we've had over 35,000 deaths. But we also need to remember that influenza has an important burden of illness every year, until perhaps this year and last year, when we weren't seeing as much flu circulating. Happy to talk about that later on if you're interested, because it's still important to get your flu shots. When we think about these conditions, we really want to understand who's at high risk for both influenza and COVID, and they're probably quite similar. So we'll run through this. rather than just having a list of people with this condition or that condition or this age group, or pregnant people or whatever are at high risk, why don't we think about it in the big picture? So is it because there are people who are more likely to get the infection in the first place? Is it because they have poor immune responses? Is it because we don't recognize, such as with older people who may present atypically with confusion or delirium and falls, rather than with the typical symptoms like a cough and a fever? And is it because they're more likely to have poor outcomes? And really, is it all of these things? So we know from years of study that influenza has a lot of potential complications. So it's not just about the lung issues and the pneumonias that we tend to think about, but there's actually a lot of underlying problems that we have seen be triggered by influenza. These include heart attacks, strokes, and importantly for us, delirium, that confusion that can happen with an infection or other illness, which then can be potentially lead to permanent changes in people's functioning and cognition, and also leading to falls and fractures. And it can also exacerbate or make worse other chronic conditions, such as kidney disorders or diabetes or frailty. So this is the influenza. And of course, we're starting to understand the similar sort of profile of long-term effects with COVID-19 as well. And it's important to think about why people in long-term care settings, for example, are particularly vulnerable. So we did some thinking about this because it's tempting to think, well, it's just because people in long-term care are older and they have higher frailty, which are both certainly true, but it's about more than that. And the important thing here is that we can do things about some of these factors. So yes, we have people who are highly frail and have a lot of chronic conditions. They also would tend to present atypically with like delirium, and that if you miss that, then you miss opportunities for treatment and infection control. But there are also important implications of this situation that they find themselves in. If there have been visitor restrictions, people haven't been able to visit and advocate for them and notice when there's a change in their health. Living in close quarters and having lots of opportunity for the infection to spread, unfortunately, has led to a lot of outbreaks. We have to think about funding and staffing and resourcing and really how we value people and workers in these settings. So it's really a multi-level response that's going to be required. Now this figure, homemade on my PowerPoint, is to really show you a summary that to me hits home quite hard about what we've been finding in these studies about the long-term impact of influenza. So here's 100 older people being admitted to hospital with influenza. Now, sadly, 12 of them will die during the admission, and 20 of them are in this group who don't recover their function. Now, the good story is that 68 of the 100 will leave the hospital with approximately the same functional status as they came in with. So you'd prefer to be in this group, even though like the best thing would be not being admitted to hospital at all with the influenza in the first place. But let's focus on these people here. So there's 20 of them here. About half of them have ended up with a measurable, important decline in their function, but not catastrophic. But these ones here, these 12 people have ended up with what we call catastrophic functional decline. So that's that they need help now with two basic activities of daily living, like bathing and dressing, for example, that they didn't need help with before. And those people, of course, are going to need a lot more supports in the community for a long time going forward. It's not just that this is after, a month after their hospital stay. It's not just a temporary thing. And unfortunately, 3 out of the original 100 people will end up having to go to a nursing home where they didn't live in a nursing home before. So really, we want to take a bigger picture and think of persistent functional decline and nursing home placements as things that could potentially be prevented if we're able to prevent that illness with vaccines and other measures in the first place. We did a survey of older people living across Canada. in relation to some of these questions. And here we were focusing on the impact of having an influenza or a COVID type of illness in the community, not even necessarily getting admitted to hospital, and the impact on their life, because people don't always think of, like preventing hospital stays. They think, oh, it won't happen to them. But things that are really important to them would be their functional independence, their ability to do work or other meaningful activities, to do caregiving for loved ones, and volunteering in the community. So we were asking specifically about those things. And what we found is that when people in these age groups, so 50 plus and 65 plus, had an influenza type illness in the community, they were unfortunately missing their usual caregiving and volunteering and work too, but we'll focus on caregiving here. About half of them had to miss caregiving for up to 3 weeks. But these ones are the ones that I want to bring your attention to. So they're still doing the caregiving, even though they're sick with the flu, and they're potentially then exposing whoever they're caring for to the illness itself, right? So we want to really drive home that that's an important thing to prevent in the caregiver, as well as the person themselves who might be vulnerable. So far, what we've done is talked about how the brain and the body are all connected. The immune system functions are really important, and frailty is a really key piece of this puzzle. It's important to understand frailty when it comes to identifying infections and treating them, and also preventing them with vaccines and other measures. So the third thing, how can we avoid frailty? What can you actually do about it? So one thing is just to reflect briefly on vaccine trials and what's actually studied in trials. So if you'll think back to the shingles study that I mentioned, these are the 4 things that tend to be studied in vaccine trials. One is the efficacy, so how well it works. One is the immune response, which now we know we need to measure more than just antibodies, even though a lot of studies, unfortunately, are still focused on that. They measure reactogenicity, or the reactions you get at the time, like the sore arm, redness, a fever, that type of thing. And they measure safety to try to make sure that there's no, bad consequences that are happening after a vaccine. And these studies are very carefully examined for all of these things. They also happen in phases. And phase 1 is small numbers of healthy participants, looking mostly at immune responses and then trying to find the right dose. And then you get into the subsequent phases. The only phase, that happens in the community, with huge numbers usually, is phase 4, which is after the vaccine has been started to be given in programs. And so I'll ask you to reflect on, when do you think frail people are included in vaccine studies? And really, it's very rare that any frail people make it into the vaccine studies that are done by, say, the companies and then are leading to the licensing. Really, the only time that frail people are included, with rare exceptions, is once it gets into general use. And I went through the literature recently to kind of see, how often is frailty considered in vaccine studies? And really, it's not very often considered. These are the studies that I found that considered it at all. And I guess we don't need to get into the details of it, but some of these ones that I've talked to you about are the sort of pivotal ones where we've started to be using it more. Now, there are some surveillance networks in other countries that are starting to use frailty as well. So there's a US one, and then there's one in India. And we've gotten frailty with that frailty scale, the one developed in Canada, is now implemented in our global influenza and COVID hospital surveillance network too. So I think there's going to be more work done on this, but certainly we need to push the field. And the reason that we need to make sure that there's frailty considered in these studies is because if you think to the COVID vaccine example, the first people to get the COVID vaccine were 90-year-old residents in nursing homes. And how many 90-year-old residents in nursing homes, say with dementia or frailty, were included in the studies? Probably not very many, if any. So it's really important that we understand how those things are going to work. And for example, when we talked at the very beginning about how you can potentially overcome some of the changes in immune function with aging and frailty, one of the strategies is using a different dose. And so if you don't include older, frail people in the studies that are finding the doses, you may miss that boat, may miss the opportunity to say, well, perhaps the 90-year-old in the nursing home would benefit from having a higher dose. So these are the types of things we need to be still understanding. This led a group of us to really consider how we can, contribute to the field, and to write this paper about how frailty and geriatric kind of principles should be considered at all stages in developing vaccines, evaluating and measuring how well they work, and implementing them into the community. And this goes all the way from designing the vaccine with, say, an adjuvant or the dose or whatnot that will stimulate immune responses best, designing the trials and recruiting older and frail people into the trials in an appropriate way, how we define the illness, because we've done some other work to show that older people are less likely to have fever and cough, for example, when they have influenza, even if they're in the hospital with it. So if you wait for someone to have fever and cough in a study to be able to then test them to see if they have the illness, you're going to miss that boat. We need to understand frailty when it comes to monitoring safety and being measured in the study in the first place. And we also need to have an understanding of frailty and age when it comes to the regulators, like say Health Canada, approving vaccines, asking the right questions about whether they've been studied in different populations, including frail people, and then getting people with an interest in geriatrics onto the advisory bodies like NACI or the equivalent in other countries, which is now just starting to happen. I know I'm sitting on NACI now, I think because of this issue that's come to light with the COVID vaccines, but also there's a colleague on this paper, Dr. Schmader, who's on the equivalent body in the US. So there is starting to be recognition of this internationally, fortunately. And then we need to think about frailty when and aging and appropriate communication to various groups, including people living with dementia and people who care for them and about them. So another way to think about all of this, and sorry if this is looking complicated, but essentially what I wanted to highlight here is just that we don't want to only focus on the person themselves who's frail. We want to focus on all the other levels of potential protection that we can bring to them. So even though it's like the Swiss cheese critical incident theory, right? So the problem arises if the insult or the influenza or infection or whatever gets through all the layers of protection. So we can block up some of those holes, even if the person who's frail and vulnerable, their own holes stay big, but if we can protect them on other levels. So we can recognize their illness better, we can have good policies in place in long-term care facilities to reduce the spread of infections. We can give staff sick time to, so that they're not working with vulnerable people when they're ill. So there's so many different things that can be done to protect people from these sorts of infections. So another thing that people wonder is what are some resources and what vaccines should we be getting at different age groups and different population groups? So here are some good links. So one is called immunize.ca. So that's Immunize Canada, and that's a really approachable reference. And I'll show you some examples of what they have on their website in a minute. Other things you can look up are the different recommendations from the public health agencies and the different for the different provinces as well. And you can read the NACI recommendations on the NACI website too. And they are a bit lengthy and wordy, but they have good summaries. So you could start with those if you're interested. So here's an example of a poster type flyer that is on the immunize.ca. So it's reminding us that immunization isn't just for kids, obviously very important for kids, but it's important for adults too. And everybody in adulthood should receive tetanus, diphtheria vaccines every 10 years. And you should have a pertussis or whooping cough vaccine too, because it's not just little kids who get whooping cough. In fact, it can circulate in nursing homes as well. So everybody should have that once in adulthood. Influenza vaccine is recommended for most people in Canada. In fact, depending on the province, but in general, it's fairly widely recommended and covered in all the jurisdictions, particularly for people who are older. pneumococcal vaccine is recommended for people 65 and older. And then there's 2 different kinds of pneumococcal vaccine. If you have questions, we could talk about that after, but one of them is recommended for everybody who's older, and the other one is recommended for certain population groups. And then for older people, we'll focus again on the shingles vaccine, which is indicated for people 50 and over, including people who've had shingles in the past. Unfortunately, though, it's only covered in Ontario, so we'll get to that in a sec. And then obviously still COVID is recommended for everybody in all the jurisdictions. So this is an example of a resource on the Immunize Canada website as well. They go by province, and you can see for your province or territory, you know, what the exact recommendation is for each of these different vaccines. So overall, what we can see with aging is an accumulation of frailty problems, so that people may become less functional and need more supports and whatnot, which has important implications for them and their quality of life and their families and our system. So what we would like to do is turn that around so that people improve on their health status, turn that frailty train around, and have people avoid frailty. And that is the name of a campaign that's been run through the Canadian Frailty Network. And you can see that the details of that at avoidfrailty.ca. And they have these 5 different things, each of which is represented by one of the letters in avoid, and the V in avoid is for vaccinate. So with that, I will end, thanking my various funders and my valued colleagues. Happy to take any questions, and I will go back to this because I think it's a nice image.
So thank you very much, Melissa. So much information and so much to take in. Thank you for explaining how frailty does affect us as we age, and understanding why someone who is older and maybe with multiple health issues that a flu or COVID-19 can hit them maybe with a stronger impact than somebody else. You've answered the question is, why do we have a special vaccine, stronger vaccine for people older than 65? And that explains it to me that, you know, the immune system changes as we age, and a stronger dose can help protect someone more. So that was really helpful. So we're going to open the floor to some questions. One of the first questions is there a connection between herpes and shingles?
Yes. So herpes is a family of viruses, and there's 3 main ones that we talk about. So there's the herpes simplex viruses that are like the cold sores, and then there's the herpes zoster virus, which is chickenpox and shingles. And so they're sort of in the same like umbrella family. Although the one that we're talking about with this shingles vaccine is the herpes zoster, which is the virus that causes chickenpox when one is young, and you know, pretty much everybody that we'd be talking about would have had chickenpox or been exposed. The problem is that it can hide out in the nerve cells and then just reappear if one is going through, you know, some sort of stressful event or with age. And so the shingles vaccine helps to prevent that recurrence as shingles.
Great. And it's my understanding that that herpes vaccine is very protective for you for getting shingles.
Yeah, so that's the one where the original studies had shown that it was over 90% efficacious in their groups. And even outside the study, we do find that it's quite effective. And that's the one that we had studied and shown that even in the frail participants in the study was over 90% efficacious. So it is a good one to consider getting. And again, in Canada, the recommendation from NACI is that it could be given to anybody over 50. It is a 2-dose vaccine, so that's an important thing. You'd want to make sure to go back for the 2nd dose to get the full benefit. And unfortunately, it's rather expensive and not covered anywhere except in Ontario. Some drug or insurance companies might cover it, but if possible, people may well be interested in the $200 or so fee, to prevent an episode of shingles, given that it's so efficacious.
Great. The next question is, and the slide up here is reminding me of it, was does aging doesn't equal frailty?
No, yeah, that's a great point. So that's part of what we try to tease out by having these frailty measures. Because if age and frailty exactly went together, then we wouldn't really need measures of frailty. We'd just be like, well, just go with age. Now, age is associated with frailty. And so if you don't have anything better to go on, then yeah, age makes sense to be an indicator. But what we can see is that actually people who are young can be frail too. And I didn't show you these results, but we have some interesting data coming out of our experience with COVID admissions to hospital, which says that among adults admitted to hospital with COVID in Canada, a lot of people are older, but not all. There's quite a number of younger adults being admitted to hospital as well. And they're not all, the frailty spectrum is represented in both age groups, right? So that there are some younger people who are frail, but there's also some younger people who are fit and still getting hit really hard with COVID. So this is an interesting message around COVID, particularly, that we want to, have the best uptake as we can to vaccines and other measures to prevent these illnesses, because there are some people, people across the whole spectrum of frailty and age who end up in hospital with that.
You also, when you were talking about the nursing homes and things that could happen, it's more than vaccination, right?
Yeah.
You talked about it's not caring for someone if you're sick, washing hands, all those other things that help protect people. Yeah. Besides the vaccines. We can't just rely on vaccinations.
Yeah, we can't rely on, vaccination is key and critical and definitely recommended for people, even the super frail people do have, benefit from getting vaccines for COVID and influenza. But we do need to think still about those other things, like in the outer layers too, right? Of generating this sort of level of a protective bubble around our vulnerable people.
The slide you have up talks about frailty, how to avoid frailty. Can you give some practical examples that we can all do tonight and tomorrow, the next day, to help start to reduce our risk of becoming more frail?
Sure, yeah. So I'd encourage anybody who's interested to look at this avoidfrailty.ca website for more details. But what they've tried to do is get evidence-based, research study-based recommendations for each of these domains. So one is to get physical activity, and it has to do with just being active, getting your heart pumping. What we usually recommend in our clinic is half an hour, 3 times a week, and build from there, kind of thing. You want to do it within the abilities and constraints that you might have, say like arthritis or like heart conditions or whatever, but it's important to be as active as we can and really build that into our daily activities. Exercising with a friend is always more fun too and more sustainable. Then we do our vaccination, like I was just mentioning, all those vaccines that it's important to keep up to date with. Optimizing medications is an important one. So there are medications that are harmful, particularly for older people. We think of sleeping pills and some of the medications that are what we call anticholinergic. So they work on certain cells in the body that can have a lot of side effects, particularly for mobility and falls, and also for cognitions and thinking. So we want to optimize medications, not be taking too many medications, but be taking the right ones. So that's important to go through with your healthcare providers and pharmacists. Then the interaction is for social engagement. Now that's tricky, of course, in COVID. You want to do it within the regulations, but as things start to open up, doing whatever you can, taking opportunities for social engagement is really important, because we know that people who are socially isolated do tend to have worse health outcomes and worse cognition and memory as well. And then the last one is diet and nutrition, which is generally about having a balanced diet. Not recommending supplements per se, but having, ideally the nutrition coming from the foods that we're eating and having a good, healthy, balanced diet.
Thank you. So here's a question. Is it possible to be over-vaccinated, or should the jabs be administered over a period of time?
Yeah, so I think the key thing there would be to follow the recommendations of the health providers and like the groups like NACI, for example. So I can tell you from my own experience now that the amount of thought that goes into every word of those advice statements is astronomical. So there's so much work that goes in to those, making sure that we have the best available data, and that we lead people on the best course that we can with the knowledge that we have at the time. And so I would feel very secure in following the recommended schedules. So if they say, you should have these, dose 1 and then wait two months and have dose 2, and you can have other vaccines at the same time in general with these vaccines, I wouldn't worry about that. The key thing is to take opportunities to get the vaccine when they present themselves, because what you don't want is to say, oh, well, I think I know better. I'll stretch out my schedule and have the next one a few months from now. And then in the meantime, you get COVID. Like, this is not a good outcome, right? So you want to do the best you can to follow the recommended schedules, because those are really based on the best evidence that we have.
Thank you. Well, we're just about out of time. There will be a poll coming on your screen. I'm going to ask everyone to take a minute and respond to that poll. Thank you, Dr. Andrews, for your thoughtful presentation. Gave us a lot to think about. This will be recorded. I think it's a presentation you can watch again and again. There's a lot of good, useful information in it. I want to thank everyone today for tuning in. Please send your comments or suggestions or topics for additional Alzheimer education to our office at 1-800-611-6345. If you'd like to have a confidential call with one of our InfoLine staff, please call that same number and we'll reach out to you. The session was recorded. Look at our ASNS YouTube channel. And again, thank you for attending today. Hope you all have a safe rest of your day. Thank you. Bye-bye.